Welcome to the Deep Dive, your shortcut to being well-informed. Today, we're tackling a really critical topic, sleep-wake disorders.
Mm,
It's something the health world is finally, giving the proper attention it deserves.
absolutely. And our sources, they really ground this in psychiatric nursing,
Mhm.
stressing that sleep isn't optional. It's fundamental to health.
Yeah, healthy people 2030 even list sufficient sleep as a national priority now.
Exactly. So our goal today is pretty straightforward. Cut through the noise, distill the key info from this chapter, the psychiatric, the biological, the nursing side of things.
We want you, listening, to come away with real clarity on how sleep works, what happens when it doesn't, and crucially, what clinicians can actually do about it.
Let's start with the consequences, because honestly, the safety stuff is pretty stark.
It really is. The material points out something quite arresting. Being awake for just 17 to 19 hours. That impairs you like having a blood alcohol level between 0.05% and 0.1%.
Think about that. That's basically like trying to function while legally impaired. It affects everything.
Everything.
Hmm.
And the chapter even links major historical disasters to fatigue, like the Exxon Valdez.
3 Mile Island, the Union Carbide explosion.
Yeah.
These weren't just technical glitches. Human error, fueled by exhaustion, played a big part. It's sobering.
And beyond those immediate safety risks, there are the chronic health problems stacking up, right? Like cardiovascular disease, type 2 diabetes.
Obesity, too, and maybe even some cancers. The link between sleep loss and metabolism is, well, it's undeniable.
How does that work exactly? The metabolism part.
Okay, so chronic sleep deprivation messes with how your body handles glucose.
Yeah.
And it throws your appetite hormones, leptin and ghrelin, completely out of whack.
Leptin tells you you're full, ghrelin says you're hungry.
Right. So when they're dysregulated, you tend to feel hungrier and less satisfied. It's basically a biological setup for eating more and gaining weight.
And the economic cost. I mean, just for undiagnosed obstructive sleep apnea, they estimate something like $150 billion in the U.S.
Yeah, from lost work, accidents. It's a massive burden, which is why we really need to understand what healthy sleep is before we can fix the problems.
Okay, good point. Let's ground ourselves in the basics. What are the key terms we need for understanding, like, the structure of sleep?
Okay, 3 main ones. First, your basal sleep requirement. That's just how much sleep you personally need to feel and function at your best. It varies.
Right, not everyone needs 8 hours on the dot.
Exactly. Second is sleep latency, simply how long it takes you to fall asleep once you hit the pillow.
And third,
Sleep fragmentation. This is about broken sleep, lots of little awakenings, shifting between sleep stages too much or just too much time in that really light sleep. It ruins the quality.
got it. So the actual architecture. We
Yeah.
cycle through different states, yeah. NREM and REM.
That's the one. We spend most of our time, maybe 75–80%, in NREM, which stands for non-rapid eye movement sleep.
And that NREM has stages within it.
It does. It gets progressively deeper. N1 is that very light, easy to wake from stage. Then N2, where your heart rate and breathing slow down a bit more.
And then the really good stuff happens in N3.
That's right. N3, also called slow wave sleep or delta sleep. That's the most restorative part. Your body's sympathetic nervous system activity is lowest then, so you're least responsive to, like, noises outside.
Okay, so that's NREM. Then we shift into REM sleep, rapid eye movement. It's a smaller chunk of the night.
Yeah, about 20–25% total.
Hmm.
But it's incredibly active mentally. That's where most vivid dreaming happens.
And the key feature of REM, besides the eye movements and dreams, is something called muscle atonia.
Yes, muscle atonia. It's essentially a temporary paralysis of your skeletal muscles. Sounds weird, but it's crucial.
Why is that?
It's protective. It stops you from physically acting out your dreams. Imagine dreaming you're running and actually starting to run out of bed. Atonia prevents that.
Makes sense. And these NREM and REM states, they just cycle back and forth.
Roughly every 90 to 120 minutes. You tend to get more deep NREM sleep earlier in the night, and the REM periods get longer towards the morning.
So what controls this whole cycling process? You mentioned a homeostatic drive.
Right, the homeostatic process or sleep drive. That's simple. The longer you stay awake, the stronger the pressure builds to sleep. Like thirst builds, the longer you go without water.
Okay, makes sense. What's the other piece?
The circadian process, sometimes called the wake drive, this is your internal body clock running on roughly a 24-hour cycle. It's managed by a tiny part of the brain, the suprachiasmatic nucleus, or SCN, in the hypothalamus.
And this clock needs cues from the environment.
Exactly. Those cues are called zeitgebers, German for time givers. And the most powerful zeitgeber by far is light.
Light wakes you up, darkness makes you sleepy. Basic but powerful.
Incredibly powerful. Light hits the retina, Signals the SCN, suppresses melatonin production,
Yeah.
tells your whole system it's daytime.
And this ties into psychiatric medications too, right? The neurotransmitters involved.
Definitely. You got wake-promoting neurotransmitters like dopamine, norepinephrine, serotonin, and sleep-promoting ones like GABA and adenosine.
So caffeine works by blocking adenosine.
Yep, blocks that sleep-promoting signal. And think about antidepressants like SSRIs. They increase serotonin, which is generally linked to wakefulness, so they can sometimes suppress REM sleep or cause other sleep changes. It's all interconnected.
Okay, fascinating stuff. Let's switch gears then from healthy sleep to, well, when sleep goes wrong, the DSM-5 has several categories.
It does. Insomnia, hypersomnolence, narcolepsy, breathing-related disorders, quite a few. But let's focus on insomnia disorder first. It's the most common complaint people bring to their doctors.
What makes it an official disorder, not just, a bad night's sleep?
Good question. It's about dissatisfaction with sleep quality or quantity. The specific criteria are trouble falling asleep, staying asleep, or waking up way too early.
Okay.
And these problems have to happen at least 3 nights a week for at least 3 months, even when the person actually has enough time and opportunity set aside for sleep. That last part's important.
Right, it's not just because they're staying up late partying.
Exactly. And to understand why it becomes chronic for some people, the chapter introduces Spielman's 3P model. It's a really useful way to think about it.
The 3Ps. Okay, what are they?
First P is predisposing factors. These are things that make you vulnerable in the first place. Maybe you're naturally a light sleeper, or you have an anxious personality type.
Okay, like a baseline vulnerability.
Precisely. Second P, precipitating factors. These are the triggers. An external stressor, like losing a job, grief, a medical illness, starting a new medication, something kicks off the sleep problem.
Makes sense. And the third P is the one that keeps it going.
Yeah, it's perpetuating factors. These are the habits and thoughts that sort of lock the insomnia in place, even after the original trigger is gone.
Like what kind of habits?
Things like spending way too much time in bed trying to sleep, becoming really anxious and worried about sleep itself, maybe taking naps at the wrong time, using caffeine too late. These behaviors inadvertently make the problem worse.
Okay. That's where interventions can really target things then.
Absolutely. A lot of behavioral therapy focuses right there.
Now moving to another disorder. Narcolepsy sounds particularly dramatic with that uncontrollable urge to sleep.
It is. It's a neurological disorder affecting the brain's control of sleep and wakefulness. And the associated symptoms can be really disruptive, even frightening.
Like cataplexy, what exactly is that?
Cataplexy is probably the most striking symptom. It's a sudden, brief loss of muscle tone bilateral, meaning both sides of the body while the person is fully awake and conscious.
So they might just collapse.
Sort of, yeah. It can range from slight buckling of the knees or jaw slackening to a full collapse. And it's often triggered by strong emotions, like intense laughter, surprise, or anger.
Wow. That sounds like that REM muscle atonia happening at the wrong time.
That's exactly the leading theory. It's like REM paralysis intruding into wakefulness. Really disorienting.
Are there other related symptoms?
Yes. People with narcolepsy often experience hypnagogic hallucinations, very vivid, sometimes scary dream-like experiences as they're falling asleep. And sleep paralysis, which is that temporary inability to move or speak right as you're waking up or falling asleep, again, feels like that REM paralysis bleeding over.
That all sounds incredibly challenging to live with.
It really is. Let's touch on a couple of other key ones. Restless leg syndrome, RLS. The chapter had a great description.
Yeah, soda pop fizzing through my veins really captures that awful sensation.
It does. RLS is this uncomfortable urge to move the legs, sometimes arms too. It's usually worse in the evening or when resting, and moving brings temporary relief, makes falling asleep a nightmare.
Any known cause for that?
The exact cause isn't fully understood, but it seems linked to dopamine pathways in the brain, and sometimes to low iron levels, specifically ferritin.
Interesting. And then there's the opposite of cataplexy, almost REM sleep behavior disorder.
Right, REM sleep behavior disorder, RBD. Here, that protective muscle atonia fails during REM sleep.
So they act out their dreams.
Yes, sometimes quite complexly and vigorously. Punching, kicking, jumping out of bed. The source mentioned a comedian who fell off furniture dreaming he was on stage. The risk of injury to themselves or a bed partner is significant.
Yikes. Definitely needs addressing. And finally, the breathing-related ones, like sleep apnea.
Primarily obstructive sleep apnea-hypopnea syndrome, OSA.
Hmm.
This is where the upper airway repeatedly collapses, partially or fully, during sleep.
Causing pauses in breathing and loud snoring.
Exactly. Snoring, gasping, witnessed apneas. It severely fragments sleep and lowers oxygen levels. It's very strongly linked with obesity, and the main treatment is usually CPAP, continuous positive airway pressure, to keep the airway open.
Okay, so we have a sense of the disorders. Let's talk about the clinical side. How does a nurse or clinician approach assessment?
Assessment is fundamental, and you have to remember it's a 24-hour issue. How they feel during the day is just as important as what happens at night. The single best tool, honestly, is often the sleep diary.
Where the patient just logs everything.
Yep. For about 2 weeks, they track bedtime, wake time, naps, caffeine, alcohol, exercise, medications, how sleepy they felt. It paints a detailed picture and really helps identify those perpetuating factors we talked about.
Are there standardized questionnaires too?
Oh, yeah. For overall sleep quality, the Pittsburgh Sleep Quality Index, PSQI, is common. It gives a score, and generally 5 or higher suggests poor sleep quality.
And for daytime sleepiness?
The Epworth Sleepiness Scale, ESS. It asks how likely you are to doze off in different situations. A score over 15 usually indicates excessive daytime sleepiness.
So you gather all this info, make a nursing diagnosis like insomnia or sleep deprivation. What are the goals then?
The outcomes we aim for are things like improved sleep continuity, getting an adequate amount of sleep, waking up feeling reasonably refreshed, fewer nighttime awakenings. Pretty common sense goals, really.
And how do we get there? What are the interventions? You mentioned behavioral therapies are key for insomnia.
Absolutely key. Especially for primary insomnia, the evidence strongly favors non-pharmacological approaches like CBT-I, cognitive behavioral therapy for insomnia, over just relying on sleeping pills long-term. CBT-I has better lasting effects.
Okay, so what does CBT-I involve? Let's break down the main parts. Sleep hygiene first.
Right. Sleep hygiene is the foundation. It covers the basics. Keep a regular sleep-wake schedule, even on weekends. Avoid watching the clock. Use the bedroom only for sleep and intimacy. No work, no TV, no doom scrolling.
What about food and drink?
Limit caffeine, especially later in the day. Avoid heavy meals or too much alcohol close to bedtime. Get some exercise, but preferably not right before trying to sleep. Basic stuff, but important.
Okay, what's next? Stimulus control.
Stimulus control is about retraining your brain to associate the bed only with sleep. Breaking that cycle where you lie in bed getting anxious about not sleeping.
How do you do that?
There are about 5 core rules. 1, only go to bed when you actually feel sleepy. 2, use the bed only for sleep and sex. No reading, no watching shows. 3, if you're in bed and can't fall asleep, or you wake up and can't get back to sleep after maybe 15-20 minutes, get out of bed. Go do something quiet and relaxing in dim light elsewhere until you feel sleepy again, then go back.
That sounds tough, but makes sense. Break the association.
Exactly. 4, keep a consistent wake-up time every single morning, no matter how poorly you slept. And 5, avoid daytime naps if possible, or keep them very short, like 20-30 minutes max, and not too late in the day.
That takes discipline. And the last main CBT-I component is sleep restriction. Sounds counterintuitive.
It does, doesn't it? But sleep restriction is incredibly effective. The idea is to limit the time spent in bed to roughly the actual amount of time the person is currently sleeping.
So if they're in bed 8 hours but only sleeping 6.
You'd restrict their time in bed to just 6 hours, maybe 6.5 initially.
Mm.
This builds up that homeostatic sleep drive we mentioned earlier.
Yeah.
It makes sleep more consolidated and efficient.
Creates a bit of sleep deprivation to force better sleep.
Sort of, yes. A therapeutic level of sleep debt. Then, as sleep efficiency improves, you gradually increase the time allowed in bed. We always have to warn patients about potential daytime sleepiness and driving risks during this phase, though.
Makes sense. Now, what about medications? You said behavioral therapy is better long-term, but are drugs used?
They are, but ideally short-term or intermittently. We have older benzodiazepines, but more common now are the non-benzodiazepine hypnotics, like zolpidem. There are also melatonin receptor agonists and newer drugs targeting the orexin system, which regulates wakefulness, like suvorexant.
And the chapter mentioned a device, too, the Cerev system.
Yeah, the Cerev sleep system. It's an interesting somatic approach. It's basically a device worn on the forehead that gently cools the prefrontal cortex.
Why would cooling the forehead help?
The idea is to reduce metabolic activity in that part of the brain, which is often associated with racing thoughts and rumination that keep people awake. Helps quiet the mind, essentially. FDA approved for insomnia.
Okay, lots of options there. Let's wrap things up. What are the absolute must-remember takeaways from this deep dive?
I'd say 3 main things. 1, Sleep problems aren't trivial. They hit overall health, safety, and mental health hard. If you see a patient with a mood disorder, you have to ask about sleep. It's almost always involved.
Okay, point one, impact is huge.
2. Assessment is vital. Don't just ask, how's your sleep? Use tools like the sleep diary. Dig into the 24-hour picture. Understand the patterns.
Point two, assess thoroughly. And third,
3rd, for primary insomnia, don't just reach for the prescription pad first. Non-pharmacological treatments, CBT-I, stimulus control, sleep restriction, these are the gold standard. They empower the patient and have lasting benefits.
excellent summary. So that leads us to our final thought to leave listeners with. We talked a lot about too little sleep.
Right, but the chapter also brings up the flip side. What about too much sleep? Regularly sleeping more than 9 hours is linked to things like increased stroke risk.
So is the extra sleep causing the problem?
Or is the excessive sleepiness a symptom of something else that's really wrong? Maybe severe undiagnosed sleep apnea that's fragmenting their sleep so badly they need more time in bed? Or maybe undiagnosed narcolepsy or hypersomnia?
Ah, so the long sleep might just be masking poor quality sleep.
Exactly. It forces us to think critically about both ends of the spectrum, too little sleep and potentially too much. It's complex.
That is a really important point to consider, a perfect place to pause and reflect. Thank you so much for breaking all that down for us.
My pleasure. It's crucial information.
And thank you, our listener, for joining us on this deep dive, for getting these foundational insights quickly and clearly. Well, you really can't beat the team here at the Last Minute Lecture. We appreciate you tuning in, and we'll catch you on the next one.